Good afternoon, good evening, good morning, everyone who has just joined us today. I hope you are all healthy and safe wherever you are. My name is Paul Ndebele. I'm going to serve as the moderator for this webinar. So on behalf of the Bioethics Interest Group, at the George Washington University. I would like to welcome you all. I would also like to welcome you on behalf of the two uh, NIH-funded programs that are supporting this webinar series. So as you are aware, this is our first webinar for this year after taking a short break. So we are looking forward to a year of rich conversations. And today we are going to be talking about vaccine ethics. I know that lots of colleagues are facing some challenges right now regarding connectivity. In fact, I had some challenges in trying to connect with the webinar myself. So our colleagues are going to continue letting in people as they come in. And I think one of our panelists has not yet joined, but we'll keep watching. So once he has joined, then I'll then introduce him. My colleagues are going to send some messages regarding professional enhancement forms. So for the students and others who need professional enhancement credits, please complete the forms and submit using the email that is going to be provided through the chat function. So without much ado, I'm going to introduce our first panelist, who is Melissa Goldstein. So Melissa is a colleague of ours on the Bioethics Interest Group. And Melissa serves as an associate professor in the Department of Health Policy and Management in the Milken Institute School of Public Health, right here at the George Washington University. Melissa is a national expert in issues around privacy and security law and also ethics. She teaches various courses in health policy, bioethics and public health ethics, health information technology policy, data ethics and public health law, and others. And she has been conducting over the years research on privacy and security legal issues. So Melissa, we are going to give you some 10 to 12 minutes to share your views on the topic of vaccine ethics. And I'm glad that our other panelists has also joined us. So please, Melissa, go ahead.
Good morning, everyone. I believe we've all had a bit of technical difficulties this morning, which of course we're used to at this point, right? It's nice to see some familiar names and faces. I even see some former students and current students, and it's nice to see you all. And I look forward to a great discussion with all of you. I apologize ahead of time. I have to leave the session a bit early at about 12:35 so that I can go teach an undergraduate ethics course. As Paul said, I am a professor here at George Washington University. I am a lawyer and an ethicist. I always say I was an ethicist first. It's my first love. And I work at the intersection of law, medicine, and ethics. I do a lot of work, as Paul also mentioned, in privacy and security sphere. I do see that our other panelist is here now, which is great. And what I'm going to do for all of you is really summarize lots of the issues. I only have a couple of slides, and it's basically a list of all of the issues that we're facing, that we've been facing. Some of them are ethics issues, some of them are ethics and policy issues, some of them you may find to be pure policy, pure law, but they're all wrapped up together. And sometimes it's very difficult to see or to separate what might be an ethics issue from a policy issue from a law issue. And they're all part of the same confusion and effort of ours to tackle this pandemic. The lessons that we've learned in the past have helped us, And certainly the vaccine research done in the past has helped the vaccine researchers who have worked amazingly quickly to get the vaccines that we're currently using on board. I would say that the ethics discussions, that the pandemics in the past, that the emergencies in the past and emergency preparedness in the past had also helped prepare us. But I also think that this may be a little different than any of us have ever experienced ever in our lives, right? Even if similar events have happened in the past, but we're in a different technology space now. So we have to think about all of the different things and think about lessons for the future. And I think sometimes some of us are able to start thinking about the future, although it's so difficult when we're all immersed in this very difficult reality of the present. So I'm sharing my screen. You'll see it's a very few slides. My contact information is here. My email address is the best way to get in touch with me now. And even my phone now goes to my email. My voice messages now go to my email. Everything is online now. So feel free to follow up with me, certainly to follow up with Paul and the people that are working with the Bioethics Interest Group, and Dr. Hyder, who I don't know has been able to join us this morning yet. I think he was having difficulties as well. So these are the issues I thought I'd start with. Vaccine distribution. And then I think we'll have a great discussion here in the Q&A session. So vaccine distribution, who gets it? And we might want to say who gets it when? Who gets it first? Who comes in last? You'll see memes all over the internet about, you know, who's in what group, who's getting it last, who's going to be the very last person to get a vaccine. It's a very difficult question. It's a difficult question from an ethics perspective. And what groups do we prioritize first? Groups of people that we might group together because of their age, for instance, which we've seen. Their illnesses, where they are housed. Are they housed in group facilities such as long-term care facilities, nursing homes? But then we might be prioritizing those people in a group facility more than we're prioritizing other groups, say prisoners who all live in a group facility where it makes it much easier, or the word may not be easier, but it makes it easier for the virus, let's put it that way, to spread. So we've got the questions about age, where you live, how many other people are there, how easy it is for you to isolate. And then we have the issues that come up with, are you able to separate yourself, and how essential is your role in our world, in our economy, in our structure as a society to functioning? So we prioritize healthcare workers, which a lot of people very much agree with, although some healthcare workers believe that they're in a place where they don't need to be prioritized and they'd rather save their doses for other people who need them more or are at higher risk of dying. So this is another idea. So vaccine distribution in general has been a very thorny topic. Then, of course, we get into the very structure of our government, okay? So this structure, I lost the screen here. The structure of the government in this country, and I believe our other panelists will talk more about other countries. We have a federal system, and those of you who are, you know, legal scholars or who remember civics, right? We have a federal system of government, and then we have state systems of government, states and territories, and Washington, D.C., where I live. And then we have local governments, which are part of the states, and the states are all part of the federal. And the Constitution of the United States divides power among them. So we have seen over the past almost year the workings of one executive administration, that of President Trump, and how that group of federal officials organized what we called, it was a warlike name for it. And we're going to tackle it. We're going to put out those vaccines. And in terms of getting vaccines out, it's been very successful. Preparation for distribution has been much more criticized of that federal system of government plans for this full-scale vaccine distribution and vaccination campaign now. And now, as of last Wednesday, we have a new executive branch of the government, President Biden, who is very quickly ramping up and issuing executive orders for how the federal government is going to treat this vaccination campaign now. So the federal government has been very heavily criticized as not giving enough money to the states for the states' roles, as not having a general plan for vaccination, getting the vaccines into people's arms, for not helping the states organize. And then you have the states. So we have seen over the past 2 months, the federal government allotting numbers of vaccine doses from Pfizer and Moderna right now. Hopefully we'll have more approved vaccines in this country at some point, hopefully very soon, and allotting numbers of vaccines to the states. States have then had problems actually accessing that vaccine quality. So they haven't been able, many of them, to get the number of vaccines that they thought that they were allotted. But then the states also have been the systems of government that are in charge of contact tracing, in charge of mask requirements, sheltering in place requirements, stay-at-home orders, stay-at-home recommendations, and everything else that we've been tackling over the past year. And states in general, state public health departments in general, are pretty much underfunded, under-resourced, both human resources and supply resources. So states are really suffering under resource straps now. And then, of course, who is it that's actually distributing the vaccines? The local governments. My parents, for instance, got their first vaccine shot from their county Department of Health. And that county Department of Health got its vaccine allotment from the state, and the state got its vaccine allotment from the federal government. But it filters down to the lowest level of government. Let's see, the people with the fewest resources, and when I say resources, I mean people that can give you the shots. I mean resources such as syringes and freezers and masks, all of these resources, but it's also people that can give the shots. So you've got the lowest level of government with, some would say, the least power, although some levels of government that are cities, such as New York City, has much more power than other cities. Washington, D.C., of course, is a city, but we have a strange way of doing things compared to other cities because we are controlled by the federal government. The lowest level of government with most often the fewest resources being given this duty without enough money, without the ability to do it well. And so there's criticism all the way up and down the board. I mentioned this issue of funding. Who pays? Where's the money come from? So a very interesting aspect of state government is that states are often required by law or even by their constitutions to have a balanced budget. They can't borrow money. Whatever money they have, whatever money the legislature has allocated, that's all they have. They can't borrow money from other countries, while the federal government actually can borrow money. That's this debt we talk about, the federal debt. So states don't have that ability for the most part. And the states rely on the federal government for money. So there was this period of time between the first quote unquote SAVE package, the CARE law that gave a lot of money to the states, before the $900 billion allotment at the very end of the Trump administration. And now President Biden is trying to get more funding for the states. And presumably that money will then filter down also to the local governments. I mentioned also supply shortages, vaccines, people. So West Virginia, I read an article yesterday, has done the best job of all of the states of actually vaccinating people with most of its allotment. I think it's something like maybe 83%. They've used 83% of their vaccines so far. They've given them to people, but that's still only 83% of what they have. And then essentially the quotations from the people in West Virginia were that they couldn't get any more, that they'd be able to give a lot more vaccines and get a much higher percentage of their population vaccinated if they could get more vaccines from the federal government. So the federal government is now trying to ramp up to help the vaccine suppliers and manufacturers to make more vaccines, although there's a limit there as well. And then we have this logistical mess. Who's in charge of actually getting the vaccines where they're supposed to be, getting the freezers where they're supposed to be, making sure that the local health departments have the allotment of vaccine that they say they're going to give out on Monday for all of the appointments they have on Monday. This was also covered in the article that I read about West Virginia yesterday. West Virginia decided to put its National Guard in charge. They decided that the National Guard knows how to do this. The National Guard knows how to send what people need, where they need it, as quickly as possible. Other states are now following West Virginia's lead in using the National Guard as a way to manage this logistical nightmare. Those of you who have managed conferences in the past or even weddings know what a logistical nightmare on a small scale can feel like. Think about this countrywide effort we're engaging in now and the logistical nightmare. So I thought I would add a few more issues onto this for discussion purposes. Vaccine hesitancy. We're all aware of the general issues of people who are worried about getting vaccines or even anti-vaccine. We have another layer of it now where a certain number of healthcare workers are actually refusing vaccines, and they have individual reasons for it. A lot of people, not just healthcare workers, are worried that the fast development of the vaccines, the limited time period in the ability to study them in different populations of people, may actually lead to worse side effects. At first, we didn't realize how serious or how many people might be affected by severe allergies. People are worried about this. So vaccine hesitancy is very much in our minds now of people who don't want to get the vaccine, because we need to achieve herd immunity in order to protect those people who cannot get the vaccine because of health conditions. We also have these new variants, some of which are already in the US. We're now talking about new travel restrictions, possibly more strict travel restrictions. There are a lot of recommendations about how strict they should be about the new variants coming into the country. And I believe our other panelists will be able to talk more about these variants if he's talking specifically about South Africa, which I think he might be. I read an article yesterday that apparently our vaccines, the ones that we are using now, don't necessarily work as effectively on the new South African variant of the virus. So Moderna said that it's working on what it's calling a booster for the vaccine, which will address that variant of the vaccine as well. And Pfizer BioNTech are actually working on such a booster as well. The timing of that, I think I read 6 weeks, they're estimating. Of course, it's an unknown. And then, of course, this last part, which I also mentioned to you all at the beginning, what's ethics, what's policy, what should we be discussing here today, or is the answer all of it? So right now I will hand it back to Paul, and we'll come back for the Q&A, and I look forward to your wonderful questions.
Yes, thanks very much, Melissa, for taking us through the issues that we are facing as a country right now regarding vaccination for COVID-19. More importantly, too, you have emphasized on the very, very strong connection between ethics, law, and policy. And you have raised so many questions about, for example, who gets the vaccine, who should get it now, who is in charge. So right now, as we look at the changes that are occurring here within the US, we're actually looking at some of those issues. We have also raised an issue about vaccine hesitancy. Later on, when our second panelist is done, I'm going to ask you both questions regarding vaccine hesitancy. You have also mentioned issues about the new variants. So later on, we're also going to have some discussions around the issues that you raised about the travel restrictions. So thank you very much for raising all those very, very important questions. So folks, I would like to encourage anyone with comments or questions to post them using the chat function. Once our second panelist is done with his talk, we can then move on to look into those questions and also comments. So now I'd like to introduce our second panelist, who is a colleague of mine by the name Jerome Singh, who is currently with the University of KwaZulu-Natal in South Africa, where he's affiliated to the School of Law. He has played very, very important roles on the African continent in terms of looking at research ethics issues. And recently, we worked together in revising the UNAIDS guidelines on how to conduct HIV prevention trials. He's also affiliated with the Joint Center for Bioethics at the University of Toronto in Canada. And he's playing critical roles in terms of looking at ethical, legal, and social and cultural issues on synthetic biology. So over to you, Jerome. Jerome, I think you are.
Yes, sorry.
Yeah.
I always try to battle to find my tab just when I need to find it. It'll never be found. So I'm just going to try to share my screen now, and just give me a second. Hi everyone, Jerome Singh, Durban, South Africa, and I'm just going to try to share my screen. Okay, so I'm hoping that you can see my screen now, but I've been asked by Paul to give an overview of what South Africa's COVID-19 vaccine strategy is. And of course, you know, I need to start off with a disclaimer that I don't represent the South African government, and the information from the South African government has been criticized as not being transparent enough. So the information that I have here is virtually all the information that is available, but I thought it would be helpful to actually just give you an overview of where things stand in South Africa with regard to COVID-19 and also with regard to what the government's announced COVID-19 vaccine strategy is. So I think important to do would be just to give you a quick overview of where the country stands in the pandemic. Our first case was reported on the 6th of March, 2020. And not too long after that, we actually assumed the title of having the biggest burden in Africa. And this has remained the case since around about April or May, once we overtook Egypt, which was an early leader. We currently have the 15th highest global burden and the 14th highest global death rate. And in terms of our stats, we actually have done about over 8 million tests so far. This is considerably more than all the other African countries. But of course, you know, again, this is just what the reported cases are. The estimates from experts and epidemiologists and modelers seem to indicate that the number of actual cases may be far more than the number of people who are presenting for testing. In terms of the total number of people who have presented for testing, we have about just under 1.5 million people who've tested positive now. And again, I want to emphasize this, this is those people who have presented for testing. The actual number may, of course, be significantly higher. The recovery rate is in the high 80%, and the total deaths have now passed over 40,000. Our cases have started to drop relatively recently, literally in the last few days. We've dropped down to about 4,500. But I just wanted to maybe emphasize and give you a quick overview here. We've had two big waves in South Africa. We peaked in our first wave around about the 24th of July, when we had about just under 14,000 cases. The second wave peaked literally just a few days ago. We had 21,980 cases, just under 22,000. So as you can see, this is quite a big difference between our first wave and the second wave. And amongst the many theories is that the second wave is being driven by the variant, which we've, of course, raised so far. So some of you may or may not be aware that the several researchers in South Africa have actually discovered that we have a variant that seems to be highly transmissible. In fact, it was discovered in the city of Durban, which is where I'm from, by local researchers. And I think it's important to mention that, you know, sometimes things happen completely fortuitously. South Africa has a very high burden of HIV. And as a result of that, amongst the top HIV researchers globally are all found in the country. So when you have about approximately 20% of the world's burden of HIV, and a lot of HIV research gets done in the country, we have a lot of very good research facilities. And the reason why I'm mentioning this is that this is the only reason why the variant was discovered. We have a lot of genomic analysis or viral genomic analysis machinery in South Africa and laboratories. And what eventually or essentially happened here was that these labs have been turned into COVID testing labs. A trend was discovered in my city where some of the clinicians were noting that a lot of people were coming in much more than would be expected. And the samples were then tested, and then a new variant was found, and soon they found that in fact it was the dominant strain in the country. I suspect that there are many, many other variants in other parts of the world, but of course, you know, the variants have to be found, and you need to do proper surveillance for that. So the US CDC is now beginning to turn its attention to doing testing for variants as part of its normal surveillance. It has not been done on any large scale in most countries. South African investigators alerted British investigators, and they in fact did a test then, and based on that found the UK variant. Brazilian variants have been found, and I suspect that there may be variants in many other parts of the world. But this is essentially what's driving the second wave, and I'll come back to this a little bit later. In terms of excess deaths, the total number of excess deaths reported, and this was just from a couple of days ago, is approximately 106,000 excess deaths. So we do mortality stats weekly, and essentially these are the number of deaths that have been reported beyond what we would normally expect. So it goes to show you that in fact the death rate is probably far higher. Some of this may of course be attributed to people who are avoiding health facilities because of fear of going into health facilities and fears of being infected with COVID or nosocomial infections. But essentially these excess death reports include COVID deaths directly and also possibly indirect COVID deaths as well, but it's quite high. In terms of what our vaccine strategy is, this has come under huge criticism in South Africa. The South African government has joined and has been a strong proponent of the COVAX facility, which of course is a WHO initiative. And the COVAX facility, of course, many of you would be aware, is driven by Gavi, which is the Global Alliance for Vaccines, the World Health Organization, and CEPI. Three of them are in fact partners in this. And as a result of the COVAX facility, 92 low-income countries will actually have advanced market commitments paid in advance to order their vaccines, and part of their cost is going to be subsidized as well. And I'll come back to this point in terms of why this is important. But the important thing to stress here is that, of course, COVAX is a multilateral initiative to try to, in fact, get demand and to, in fact, secure stock for low and middle income countries. South Africa is also part of a regional initiative that's under the umbrella of the African Union, and essentially the African Export-Import Bank, which is, in a sense, the shareholders of all African governments. They're going to be facilitating payments for advanced procurement, and this is being done directly on behalf of the African Union. And this is being done for 55 member states of the African Union. So this was not something that has been long in the making. In fact, this was announced relatively recently in the last few weeks. And what this does is that the African Union has announced that about approximately 270 million vaccine doses have been ordered from Pfizer, Johnson & Johnson, and AstraZeneca. And this is separate from the COVAX facility. Aside from all these different initiatives, the South African government has come under huge criticism for, in fact, possibly not acting fast enough. And as a result of huge criticism, both from civil society and other scientists, in January 2021, the government announced that they had actually been negotiating and trying to procure vaccines directly from vaccine manufacturers. And the Serum Institute of India is the facility that they've actually approached to buy 1.5 million doses of AstraZeneca. And the rumor mill has it that, in fact, the vaccines arrived today in Johannesburg from India. That's what the rumor is, because there was a direct charter flight that from an airline that is being used to transport vaccines. So the vaccines may have arrived in the country, but essentially this is going to cover 750,000 people, essentially. The first delivery, as I said, was expected before the end of January, and that's more or less what's going to happen. So if it didn't arrive today, it should arrive by the end of this week. So we've got essentially 1.5 million doses potentially in the bag. But what are the vaccination goals of South Africa? Well, the population of South Africa is approximately 59.5 million people currently. And to achieve herd immunity or population immunity, the country needs to vaccinate approximately 40 million people. This is a big ask. So if you ask yourself, we've got 750,000 doses or doses for 750,000 people. If you divide 1.5 million by 2, and you need 2 doses each, we've got a long way to go in terms of achieving population immunity. In terms of how are vaccines procured, it's being done solely by the federal government or the central government, and provincial governments have in fact put up their hands to say we want to actually procure our own vaccines. The central government has said that that would not be permitted. So in South Africa, we have a system where both federal level government and provincial governments or state level governments have co-competency when it comes to health issues. So not all the states are ruled by the same party. 8 of the states or provinces, as we call them in South Africa, are ruled by the same party that rules at the central level. 1 province is ruled by the opposition party. They've actually said that the government or the central government is moving too slowly. They would prefer to procure vaccines themselves. This is something that will be probably quite difficult for them to achieve for various reasons, which I don't want to go into here, but including that they may not be able to get probably very good prices in terms of economy of scale. In terms of where will the funding be coming from? Well, National Treasury said that they would be providing most of the funding, but a public benefit organization, which was in fact launched not too long after COVID, in fact, emerged in South Africa, called the Solidarity Fund, they've in fact paid the deposit for the COVAX facility. So this is made up of voluntary donations by members of the public, corporates, and the non-government organizations. Also, the South African government puts money into that. So the COVAX deposit has been made by the Solidarity Fund, and private health insurers have also said that they would actually be prepared to sponsor not just their members, but also uninsured people as well. The corporate sector has also stepped in to say that they would actually fund vaccines as well. So major corporates, especially the mining community and others, have said that they would be prepared to sponsor their employees and also possibly neighboring communities as well. So in terms of funding, the funding is there, seemingly, even though the government has said that they may in fact seek assistance from major multilateral institutes like the World Bank. But essentially the funding is there. The major issue is not so much the funding or the procurement, even though I think the government did leave it for too late. But I think the major issue is also in terms of where are the vaccines going to come from. So, this has been in the news quite a lot. And the government has already said that we need, first of all, to have a priority framework established. And so the prioritization strategy of the government right now is to divide vaccine delivery into 3 phases. The first phase will involve healthcare workers. The second phase will involve essential workers, teachers, the elderly, and those with comorbidities. And the third phase will involve other adults in the population. At this point in time, there's no recommendation or there's no clinical trial results for the inclusion of children, even though, of course, we do have a few trials now emerging with efficacy results for 16 years and above, and some trials have started enrolling children as young as 12. But at this point in time, the government hasn't announced anything about that. But the priority right now is healthcare workers, and this would be essentially frontline healthcare workers. The major challenge, of course, is that there's not enough doses that the government have procured so far or secured to enable all the phases to be done. And I think one of the major challenges that South Africa faces as a middle income country is that, and I said that I would come back to this, is that there's several different challenges that the country is facing. And I'm going to look at the ethics issues first in terms of what is happening at a domestic level. From an ethics perspective, I think the government has been slow to procure vaccines. So there's an accountability issue and a transparency issue. So what the public knows so far is that the government has missed 2 COVAX payment deadlines, and the deposit was only paid on the 22nd of December 2020. And this was, again, funds from a public benefit organization that was established to respond to COVID-19. There's been a lack of transparency in terms of which are the preferred candidates. The government has given an indication that they may, in fact, or will be looking at AstraZeneca, possibly Johnson & Johnson. There is a bit of resistance towards Russian and Chinese candidate vaccines in the country, but there's also been a lack of details regarding how the deployment will occur. So at this point in time, the private sector has to be involved, but it's not quite clear whether this will be done at pharmacies, whether this will be done at hospitals, clinics, whether GPs or general practitioners in the community will be involved. The delivery timelines are also unclear. So at this point in time, the government has only said that they've secured 1.5 million doses. Well, those 750,000 people will be the frontline healthcare workers, and there's not really clarity in terms of how it will be divided up between the different provinces and the states, how it will be divided up between healthcare workers in the state sector and private sector, and also in terms of who is covered. So this is an important ethics issue as well. In terms of universal coverage, the government has kind of like given the indication that this would be sponsored fully by the government. And generally, this is considered to be possible to cover nationals and permanent residents, but it's not quite clear yet whether migrants and refugees will be covered. So the president gave an indication that everybody in the country would be covered, but in terms of how will access to such individuals be managed, that is not yet quite clear. So I think it's important to note that while we have 59.5 million people in South Africa, not all of those 59.5 million people are nationals. There's a huge humanitarian issue in surrounding countries. So estimates right now indicate that there could be up to between 4 to 5 million Zimbabweans in South Africa. There could be hundreds of thousands of Mozambicans. We have hundreds of thousands of refugee applications from other parts of the country, other parts of the continent. And it's not quite clear whether those populations are going to be included. And while there is a commitment to include them, but the timeline of when those people will be in fact covered is another issue altogether. And there's no clarity on that. So I think, these are the micro ethics issues at a domestic level. But I think important to note is that, and this has been something that I'm sure many of you have heard about, is that we do have, of course, ethics issues at a macro level as well. So we do know, for example, that there's a major, as commentators have been calling it recently, a hoarding on the part of affluent countries. I don't, in my opinion, think that that's a relevant term at this point in time. It's not as if affluent countries are sitting with tens of millions of stock, but they've pre-ordered tens of millions of stock. So countries like Australia and Canada, for example, have purchased stock that covers more than 3 to 5 times their population sizes. And at this point in time, estimates by Gavi indicate that, in fact, affluent countries have got 800 million extra doses of vaccines more than what they would need. That's if all their orders come to fruition, whereas there's a major shortage in low and middle income countries. So a report from literally just a few days ago indicated that in terms of low income countries, in terms of total number of doses administered so far, 25 doses have been administered as of the 18th of January in low-income countries. Middle-income countries have started rolling out deploying vaccines. South Africa belongs to the category of middle-income country, and in fact, it's an upper middle-income country. The reason why this is important is that as an upper middle-income country, South Africa does not get discounted rates through the COVAX facility. And what this means is that, in fact, it's quite difficult for the government now to, in fact, put all its eggs in one basket and to, in fact, get its vaccines from COVAX, when, in fact, it may be able to procure doses directly from manufacturers at a far lower price. So this is, of course, a criticism towards multilateral initiatives like COVAX, where the funding, in fact, favors low-income countries over middle-income countries. And what you end up then having is a situation where middle-income countries have to then, in terms of maximizing their budgets, they have to, in fact, procure vaccines directly from manufacturers. What this means is that you then have middle-income countries competing with high-income countries with international institutions that like the COVAX facility, where they're also trying to procure vaccine doses. So I think, what may have been probably a better option is if middle-income countries will also offer discounted rates or the same discounted rates as low-income countries. Because what you essentially have now is, while 92 low-income countries are covered by COVAX at discounted rates, all the other countries that are middle-income countries, including upper middle-income countries, if they want to maximize their budgets, they're going to have to procure vaccines directly from manufacturers and, of course, then compete with each other and also compete with multilateral institutions and compete with high-income countries. So this is the situation that countries like South Africa finds itself in. There are many other countries like South Africa that are upper middle-income countries that are finding themselves in the same situation. So countries like Mexico, Brazil, South Africa, Turkey, all of them are classified as upper middle-income countries. And all of those countries that I mentioned are, in fact, having to pay higher rates for vaccines purchased through the COVAX facility. So in terms of concluding in discussion, I'm happy to take questions on these issues, but this is just to give you a quick snapshot of one upper middle income country in Africa. And of course, as I mentioned, just to conclude, South Africa has the highest burden in Africa by a considerable margin. It has very unique challenges in the African context because it has such a high burden, but it's also classified as an upper middle income country. It's trying to secure doses through 3 different initiatives in parallel. That is through COVAX, through a regional African initiative that is being organized by the African Union, and of course, direct procurement with vaccine manufacturers and developers. So I'll end there, and I'll be very happy to take questions from people once we reach that point. Thank you.
Yep, thank you very much, Jerome, for sharing your views with us. You have raised so many issues, and I'm sure participants have got lots of questions. You have raised the issue around the migrant populations and whether they are going to have access. You've also raised at the international level an issue about the power of the rich countries to buy in large quantities, and then nothing is left over for the low-income countries. You have also shared with us the South African strategy, but also shared with us, the fact that there was slowness on the part of the government to act, and even right now for us in the US, we are seeing some of the slowness in terms of strategizing to ensure that vaccines get into people's arms. I'm going to start by asking Melissa a question around vaccine hesitancy. A lot of the people who are talking about, who are not willing to have the vaccines, are asking questions about the speed with which we ended up, coming up with these vaccines. And some of them are saying, look at HIV, look at cancer. We've spent so many years working on vaccines, and yet with COVID-19, over a few months, we now have vaccines. What can be done to ensure that we convince those people to accept the vaccines? Melissa?
It's very interesting because you have, for the most part, healthcare workers are employed, or at least the ones that are seeing COVID are employed by hospitals, these particular, or other healthcare institutions. So they have an employment arrangement with their institutions, and theoretically, the institutions could, depending on what those agreements say, require healthcare workers to receive the vaccine in order to work at the institution. I have not seen that, though. I've looked for it in the press, and I haven't seen a lot of reports for that. And what I think is that we're really pressed for human resources right now to begin with, to treat the massive influx of COVID patients and hospitalization of patients, but also all of the other things that all of us always go to hospitals and our physicians to be treated with, right? So those issues haven't disappeared. And Dr. Singh was talking about the waves of the virus that we've seen, and the fact that our healthcare workers have been doing this now for almost a year, for close to a year, right? And the exhaustion and the personal exhaustion and the stress on themselves and their families. If we think about what they're going through, it's big. It's very big. So how do we convince them to get the vaccine? First of all, the people that interact directly with patients are the people that, and especially COVID patients, are the people for whom it's most important, especially if they interact with both COVID patients and non-COVID patients, right? They could be vectors of transmissal. So I would think that we would focus our communications to them. Beyond that, we have to think about principles of ethics, right? So we think about beneficence, we think about non-maleficence, so doing good, beneficence, and not doing harm, non-maleficence. How do we make these decisions for individuals? And does becoming a healthcare worker mean that you no longer have any autonomy? No decisions for yourself, that you can't put yourself or your family first under any circumstances? Generally, our answer to that is no, and that this is a balance, that healthcare workers also have a certain degree of autonomy. Does that change in a crisis? And we've developed what are called crisis standards of care. So what happens in an emergency? All hands on deck, right? And what has happened in DC in really major snowstorms, very rarely, but it still has happened, is people are spending the night in the hospitals because they can't go home. So this has happened also with COVID. What do we require of people? It's a very complicated question. If they want to work in a position where presumably they take the position and they study for it and they train for it because they want to help other people, what are the obligations that they take on then? And how far do they go, those obligations?
Thank you very much, Melissa. If you still have a few more minutes, Melissa, I can ask a second question.
Yeah. Was that for me?
Yes, right. So we are looking at the travel restrictions that have just been reintroduced, right? And yet we are also looking at a country such as South Africa, which is now going to start vaccinating their persons. And South Africa is now part of the travel restrictions. So the question is, for those South Africans that have been vaccinated, right, should they be accepted for travel into the US? What's your view?
Paul, was that for me or Dr. Singh? I had a little bit trouble hearing you. I'm sorry. Okay, could you repeat it? I'm sorry.
Right, I'm talking about the travel restrictions. And I'm talking about specifically, let's say South Africa, which is now going to start vaccinating, and yet it's now part of the travel restrictions. So for those South Africans who receive the vaccination, should they be allowed to travel into the United States?
That's a great question. I read an article this morning about what countries had imposed on their borders very strict travel restrictions, and what had done none, and then the US has done somewhere in between. So if you remember our very first travel restrictions on China and then Europe, basically travelers from Europe, they were not restrictions on our own citizens. So we let our own citizens come back in, even though they were traveling from the same place where the same virus was spreading, right? And there was a wonderful quote that I read in this article this morning that said, a vaccine does not recognize a passport, right? Does not recognize your place of citizenship. In contrast, Australia, basically anyone that came into the country had to stay in a hotel for 2 weeks. A hotel, not at home, because what has been found is that quarantines are the most effective if you're not at home, and that people will be most adherent to the requirements if A, it's enforced, right, from the outside, and B, if it's not at home. Australia was also using its military to help enforce the restrictions that you had to stay in this hotel for 2 weeks. And because it was 2 weeks, it eliminated most of the tourists, right? Because then you're not going to spend 2 weeks of your vacation in a hotel and then possibly when you get home. Are we willing to do that for South Africa? I doubt it. So our travel restrictions right now, I haven't read it. Do you know whether we're letting our own citizens back in or not? I'm assuming we are, and close relatives to our own citizens, right? Now, the question about vaccinated South Africans, if they have both vaccines, they're in just as, if they've gotten both shots of the vaccines that we are using, I really don't see a distinction between a South African citizen and a US citizen in that respect. If they are getting vaccinated with vaccines that have not been approved here yet, I can see people making a distinction, although might not necessarily make that distinction. I can see others making it. And we're also letting people in who have had recent tests that are negative, but as we all know, that could change the next day in terms of testing. Testing is a spot in time, not a long time in time. So this has been a great session, and I wish I could stay, but unfortunately I have to leave. But thank you, Paul. Thank you, Dr. Singh. Thank you for everybody. And please stay in touch if you want to chat about this more. Thanks.
Thank you very much, Melissa. All the best with your class that is just coming up now. So all the questions now are going to Jerome. So Jerome, you mentioned the South African vaccination strategy, and on the priority there, we actually have healthcare workers. And yet we know that some of the healthcare workers are going to refuse vaccination. So the question is it ethical to allow healthcare workers who refuse to get vaccinated to work in the healthcare facilities?
That's a great question, Paul. And I think that there's no international consensus on this issue yet. I think for those of you who have legal backgrounds, you will know that an employer can make your re-entry into a workplace conditional upon vaccination, and that can be done as an occupational health and safety measure. So you'll find that healthcare workers theoretically could be denied access to their workplace if they fail to be vaccinated. And this is a very common strategy used in many countries. So for example, if you're an airline steward and you want to travel to a particular country that's in a yellow fever zone, your employer will not employ you or will not put you onto that flight unless you've been vaccinated against yellow fever. So you'll find that a similar principle applies in the context of healthcare workers. An employer may in fact impose mandatory vaccination on their employees. Now, of course, there could be many, many different reasons and legal challenges and human rights challenges to a mandatory vaccination policy. But my point here is that it would be, in many cases and in some settings, legal to in fact impose a mandatory or conditional entry to a workplace and make that conditional upon vaccination. Now, of course, it's a separate issue, and we're not going to even go into too much of detail here, but I think people need to maybe just be reminded that being vaccinated against COVID at this point in time, the evidence is showing that in fact, it may prevent you from getting severe disease, but it doesn't necessarily mean that you're prevented from being infected. And it doesn't mean, and there's no evidence here to show that in fact, you will not transmit the disease to other people. So I think it's important just to remind everyone who's now suffering from shock and falling off their chairs, but what the evidence and the way the clinical trials have been structured is to in fact show whether COVID-19 vaccines prevent severe disease. And essentially all the vaccines that have been tested so far that have shown positive results are showing that the vaccines seem to prevent lower respiratory infection. They don't necessarily prevent higher respiratory or upper respiratory infection. And what this means essentially is that you could have a situation where you could be vaccinated against COVID, but you may not necessarily be immune from being infected with COVID. You just won't become sick or severely ill. But you could, in fact, possibly, and this is what the evidence, we're still waiting for evidence on this, but you could possibly still transmit COVID to other people. So I think, even though a healthcare worker or anybody else may be in fact vaccinated against COVID, we don't know yet whether COVID vaccination will prevent other people from being infected by that person. So these are all the unanswered questions in science. There's more research that's being done to test this, but current vaccine trials are not designed to measure whether in fact the vaccination prevents transmission. We just know it prevents severe disease.
Thank you very much. You raise a very, very important issue about migrants in South Africa. And when I look at migrants, they are mostly settled in the in those areas where they are large numbers. You are looking at Durban, you are looking at Joburg itself. So when you look at the South African strategy, it actually has categorized some high-risk individuals who are supposed to receive higher priority when it comes to vaccination. Now, when you look at migrants, you also have the same categories of those high-risk individuals, the individuals who are at high risk for COVID-19. Should they be considered together with the South African citizens when it comes to vaccination? That is point A. The second part is, should the government consider whether they are legal or illegal migrants? What's your view?
I think that the challenge is, first of all, when you look at how the government in South Africa and many other governments are looking at doing a prioritization, they're prioritizing frontline healthcare workers as the first priority group. And you'll find that in terms of healthcare workers, if you're a migrant, you'd have to be a healthcare worker who's in fact employed at the health facility. So you'll find that if you're a healthcare worker and you're a migrant, but you're not employed, you won't necessarily qualify for prioritization. Just being a healthcare worker doesn't mean that you will be prioritized. You have to be a frontline healthcare worker, and by being a frontline healthcare worker, you're probably part of the formal employment system in the country. I think where things become a bit more tricky is when you start looking at groups beyond the frontline healthcare workers, and you start looking at, for example, not just healthcare workers, but you start looking at, for example, elderly people. Because when it comes to elderly people, you're going to have people who are, of course, migrants who are elderly people as well, and not part of the formal economy or formal employment. And there you'll find that's where the government will have to start making very difficult decisions, because of course, if you're a migrant or legal or illegally in the country, you're going to have to, of course, be prioritized for protection. And that's where I think the challenge will be, is to, in fact, figure out how you're going to do that. And the reason why I say that that could be a particular challenge is that a lot of migrants in many countries, including in the United States, are undocumented. And when you're doing a vaccination campaign, you need very clear documentation in terms of who's been vaccinated, what dose they have, what vaccine they received, etc. And to do that, you're going to have to be documented, because we need to capture you in the system to know whether you've received any doses, which dose, and how many days apart, etc. So you'll find that those are one of the big challenges that I think migrants are going to face in many different settings, is that to be vaccinated, some of them are going to have to be processed and documented in some way. And I think that the risk there is that those who fear deportation, for example, may in fact avoid vaccination for fear of being documented, because if they're documented, then of course they could be detected. But I think that we can't be naive to the fact that while migrants and refugees and asylum seekers need to be vaccinated, to be vaccinated, they need to be documented, because that's the only way you're going to have a good comprehensive vaccine registry to keep track of who has been vaccinated and what doses they've received. Thanks.
All right. Thanks so much, Jerome. You have raised so many issues, and I think we actually need to devote another webinar just to look at all the issues that you have raised. So now it's time up, and I'm going to give you some 30 seconds just to give your final words on all these issues.
Okay, final words. Wow. Okay, very quickly. I think in terms of this being a group of scholars and emerging scholars and students and budding ethicists, established ethicists, but I think amongst the issues that you should be considering right now in terms of a very topical issue is that Moderna announced that they are working on a vaccine, modification of the vaccine to tackle the South African variants, because unlike the British and the Brazilian variants, and we're calling them by those names, but in fact, it's actually not good to call variants by nationalities. They should be called and designated according to their, how they've been classified, and they've got special codes attached to them. But just for ease of reference, I'm going to call it the South African variant for now, for the purpose of this talk. But Moderna has indicated that they will modify their vaccine to cater for the South African variant. But I think the big question here from an ethics and equity point of view is if Moderna is modifying their vaccines to ensure that it covers and protects against the South African variant, will South Africans be getting that vaccine? Because Moderna has not made any indication that they would be providing vaccines to low and middle income countries. Pfizer has said that they would. In fact, Pfizer said that they were going to be providing, I think, about approximately 40 million doses to low and middle income countries. Cost, right? But Moderna has made no such indication or promise yet. And essentially, the first few 100 million doses are being produced for the US, and then, of course, in priority, of course, Canada and the European Union. So if the biggest country of burden for that variant is South Africa, there's an ethics issue then that surely people in that country should be getting that vaccine to protect them, because there's relatively few recorded cases of the South African variant in the United States. So if there's a variant that in fact may pose a problem to vaccines, then surely the country that has the biggest burden of that variant should be prioritized for that modification of that vaccine. So unless and until Moderna gives us that indication that they are going to be prioritizing access to South Africans for that vaccine, it's a moot issue whether in fact you're providing a vaccine modification against that variant, because those who really need it need to get it. And in that respect, I think the ball is now in Moderna's court to indicate whether in fact, if they make this modification, whether they will be pledging to make this vaccine available to countries like South Africa. Over.
Thank you very much, Jerome. I just hope that you can write a quick paper on that very, very important and interesting topic. And once again, thanks very much for accepting our invitation to come and serve as one of our panelists on this webinar. So thanks to you and Melissa for the words, your opinions that you provided during this webinar. To everyone who joined us today, thank you so much for joining us from wherever you are. We look forward to having you again in our next webinar. So look out for the invitations. So thank you very much and goodbye.